Hi guys, so we'll be studying dermal cysts today. Dermal cysts are also known as choristomas. A choristoma is basically a mass of histologically normal tissue, but it's in an abnormal location. So the tissue is not the issue, the location is the issue. So this is an orbital dermoid cyst. Dermoids are lined by keratinized stratified squamous epithelium like skin and have a fibrous wall and contain dermal appendages such as sweat glands, sebaceous glands, and hair follicles. Epidermoid cysts do not contain adnexal structures. Dermoids may be superficial or deep, located anterior or posterior to the orbital septum, respectively. Epibulbar dermoids and dermalipomas are also related lesions. Diagnosis: dermoid cysts are one of the most frequently encountered orbital tumors in children. Symptoms: a superficial orbital dermoid cyst presents in infancy with a painless nodule, most commonly located in the superior temporal and occasionally the superior nasal part of the orbit. So you have dermoids that are generally seen in the superior nasal or superior temporal part of the orbit. And it's a painless nodule seen at infancy. A deep dermoid cyst presents in adolescence or adult life with a gradually increasingly protruding eye, or acutely with an inflamed orbit due to rupture. So superficial dermoid cysts are seen early in the life, whereas a deep dermoid cyst starts to present only in adolescence with a protruding eye as a sign. So the signs for dermoid cyst are different for superficial and deep dermoid cyst. A superficial dermoid cyst will look like a firm, round, smooth, non-tender mass 1 to 2 centimeters in diameter. It is mobile under the skin but usually tethered to an adjacent periosteum. The posterior margins are easily palpable, denoting a lack of deeper origin or extension. That is how you find out whether it is deep or superficial. Now, a deep will manifest with a proptosis or a dystopia or a mass lesion with indistinct posterior margins. Investigation: superficial imaging shows a well circumscribed heterogeneous cystic lesion. Deep imaging shows a well circumscribed lesion. Some deep dermoids associated with bony defects. So, under investigations, you can do an investigation for superficial, which shows well circumscribed heterogeneous cystic lesion, and a deep dermoid cyst will show a well circumscribed lesion. Some deeper dermoids can also have some bony defects, which may extend inferior temporal into the inferior temporal fossa or intracranial. Treatment for dermoid lesions are observation and possibility of rupture should be observed for, and if they're inflamed, then give them oral steroids. So for a superficial dermoid, you're supposed to do an excision in toto and do not rupture the lesion, because leaking of the keratin into the surrounding tissues typically results in severe granulomatous inflammation. Deep dermoid is also excision in toto is advisable because deep dermoids enlarge and may leak into the adjacent tissues, inducing inflammation often followed by fibrosis. If incompletely excised, dermoids may recur with persistent low-grade inflammation. This is where the orbital dermoid cyst is seen. This is a superficial dermoid. Now this is a deep dermoid that is not so apparent superficially, yet you can see that there is some inferior dystopia and there is some protrusion in the superior part of the eye, and also there might be a proptosis here. Dermal lipomas are more frequently on the bulbar surface and are generally solid rather than cystic. Surgical excision is much more difficult because of unsuspected extension and periocular infiltration. Unsuspected extension and periocular infiltration. So what is happening here is the dermal lipomas are more frequently on the bulbar surface. So while dermoid cysts were seen on the superior nasal or superior temporal lid areas, dermal lipomas are seen in the bulbar region and a lot more solid. So these are one of the cardinal differences between these two. That is how you differentiate. So choriostoma is a normal tissue and an abnormal location. Contains ectodermal elements such as skin, hair, fat, and sebaceous glands, like you've already seen. It's well circumscribed. White, pale yellow, round lesion, flaccus meridian of the cornea, is adjacent to the dermoid. There is no malignant potential, so this could be like a key point. There is no malignant potential. It is associated with golden heart syndrome, and dermoids contain ectodermal tissue. Muscle is not expected in a dermoid. So this is adjacent to the most flaccus meridian in the dermoid. It is an ectodermal tissue. Here you can see there are some hair follicles that are seen in this area, and there are other sebaceous glands and sweat glands also accompanying a limbal dermoid. This would be called as a limbal dermoid since it is present at the limbus of the cornea. Now let's have a look at the vascular tumors. Under vascular tumors, we have varices. Pyramidal orbital varices are a combined venous and lymphatic malformations of the orbit. They consist of a plexus of thin-walled, distensible, low-flow vein-like vessels that are commonly, though not always, intrinsic to the normal circulation, but they are generally supposed to be normally present in the right location. They are probably hematomatous. Hematomas are a disorganized overgrowth of mature tissues that normally present in the involved area. So the difference between a choriostoma and a hematoma would be choriostomas are abnormal locations, whereas hematomas are normal, or let's call them abnormal tissues and normal locations, where these are normal tissues. This is locations. So that is how you differentiate between a choriostoma and a hematoma. So varices are hematomas, which mean they are the normal location, but they are the wrong tissues or malformed or disorganized tissues. Now, these are unilateral and have an intermittent non-pulsatile proptosis, but there is no browate, which is a key factor. They are accentuated by increasing venous pressure through coughing, straining, or the Valsalva maneuver. Complications for varices include acute orbital hemorrhages, thrombosis, pain, proptosis, decreased vision. Long-standing lesions may develop atrophy of the surrounding fat, giving enough thalamus with a deepened superior sulcus. Small lesions generally do not require treatment. Specialized techniques such as embolization and carbon dioxide laser surgery may be helpful. Indications for surgeries will be recurrent thrombosis, pain, severe proptosis, and optic nerve compression. There is a lobulated mass of varices present in the conjunctiva of the upper lid. Now this is varices present in the conjunctiva, bulbar conjunctiva, and this is orbital varices before Valsalva, and this is after Valsalva. Now there seems to be some proptosis that has been induced on straining. Now this is showing phleboliths or opacification medially on CT, and there is atrophy of the fat in the left eye, which causes it causes an enophthalmos. The varices are a venous structure that usually would not have sufficient blood flow. They do not have sufficient blood flow. That's why there is no browate. The classic presentation is proptosis with Valsalva maneuver. That is a key point. Then CT would show the demonstration of the various enlargement during a Valsalva maneuver. The lymphangioma is a rare hematomatous vascular tumor that tends to enlarge and infiltrate diffusely with time. So they can enlarge with time. This is a variant of varices. Although usually isolated from the main circulation, bleeding into the lumen may occur with subsequent formation of blood-filled chocolate cysts. May regress spontaneously. They present in early childhood, similar to a superficial dermoid. Differential diagnosis is principally from orbital venous anomalies and hemangiomas. Intracranial vascular malformations can be present in association. Diagnosis shows a soft bluish mass in the upper nasal quadrant. So as you can see, the limbal dermoids, orbital varices, and lymphangiomas all tend to present in the upper nasal, whereas there is exception in the limbal dermoid that can present in the superior temporal part of the orbit also. So posterior lesions may cause slowly progressive proptosis or initially malignant diamond and later present with a sudden onset of painful proptosis. So similar to orbital varices, they can also present with a painful proptosis or secondary to a spontaneous hemorrhage. So secondary to a spontaneous hemorrhage is also another complication associated with orbital varices. Similarly, optic nerve compression also. It may also involve the oropharynx along with the lids and conjunctiva. Intracranial lesions also may be seen. Treatment. Visual prognosis is good without treatment. Surgical excision is difficult because lesions are unencapsulated. They bleed easily, are friable, and commonly infiltrate normal orbital tissues, so repeated subtotal excision may be necessary. Persistent sight-threatening chocolate cysts can be drained or removed subtotally by controlled vaporization using a carbon dioxide laser. So this is a diagram that shows an orbital anterior lymphangioma with typical bluish discoloration. So that is one of the key points that we had studied earlier. They present as soft bluish masses. Now moving on. This is a severe painful proptosis due to lymphangioma from a posterior lymphangioma. Axial CT shows proptosis and orbital opacification. Conjunctival involvement, and this is an oral lesion, as it also sometimes affects the oropharynx.
Hi guys, you did a great job sticking till the end of the video. As you guys know, I love talking about ophthalmology stamps, and there's a new stamp every video. The stamp for this video is of course the Syrian stamp of the Second International Congress of Pan-Arab Congress of Ophthalmology, PACO, which features the eye and the eye chart. It looks like a tumbling C chart. And then we have another Syrian stamp as well, issued in 1993, the 25th anniversary of National Ophthalmology Association commemoration, which shows the landscape of Syria with the eye and the rainbow surrounding the eye. Sticking till the end of the videos for new stamps in H1.
Guys, if you like this channel, please consider subscribing and sharing this channel amongst your friends, your medical students, medical graduates, undergraduates, postgraduates, the like of them. And if you like my content, please consider liking it, and please do leave a comment. I read all your comments, and all and any feedback is welcome. This is part of the revision series that I just wanted to do since I wanted to prepare for my exams. I hope these help you out too. Thank you for you too.